Hi, this is Brian Kim. I'm going to share with you this case of a patient who was referred from out of town. This patient had a complex cataract surgery, posterior capsular rupture, and then the surgeon put in an anterior chamber lens. The patient had a decompensated cornea, so she was referred to me. I was watching this patient. The cornea finally cleared, and as I continued to follow her, I noticed episodes of high pressure, so I decided this patient has an UGG syndrome. So you're going to see me take this anterior chamber lens out through a scleral tunnel, and then performing my modified Yamane technique using the AR40 lens. You can see that this is the anterior chamber lens, and this is a 5/0 silk suture, traction suture temporally, and I'm rotating the eye nasally. I ink the conjunctiva, which will allow me to better approximate the conjunctiva at the end of the case, and I'll perform a temporal peritomy for the scleral tunnel. After performing the peritomy, do a little bit of cautery. And starting around 3.5 millimeters posterior to the limbus, I make a groove, partial thickness groove, no different from doing an extra cap or an M6 case. You want to make sure you're deep enough, but not too deep that you perforate. Of course, if you perforate, you can get iris prolapse if you're not careful. And then holding the eye with some forceps, I try to get deep within the groove, and then I start to wiggle to create the scleral tunnel. The main thing is you don't want to enter too soon, but also you don't want to have too shallow of a tunnel, and then you'll just rip through the roof. And so far so good. I'm trying to start centrally wiggling towards the limbus, and then wiggling towards the left, and then wiggling towards the right. Inject some dispersive viscoelastic within the tunnel to create some space, lifting the roof of the tunnel. And this is a 3/0 keratome blade. Stay nice and flat and enter the center. And then widening with the crescent blade. Using 2 microforceps, I hold the optic of the lens and then grabbing the proximal haptic. And you know the haptic has 2 bends to it. These ACIOLs are designed that way. But you can see the tip of it broke off. So I'm grabbing the rest of the haptic to try to pull the lens out. The incision is a little bit tight. So I'm holding the lens and then using another set of forceps to lift the incision. I pop it out. But you can see there was some resistance. Why? Because the distal end of the other haptic also broke off. And so there is the other tip of the haptic on the other side. It's wedged into the peripheral iris tissue. So I'm trying to determine if I should take this piece out, seeing if I can just push the iris tissue off the remaining haptic remnant. but I can see it's really kind of tethered deeply, and the more I pull on it, the more it's bleeding. And since it's not in the angle and it's not touching the cornea, I decided to leave it. So I inflated the eye, and this is an 8/0 nylon suture, and I'm going to place 2 interrupted sutures, and I placed it in such a way that the knot is buried. So nice solid suturing of the scleral tunnel, and then closing the conjunctiva with 8/0 vertical suture. And now that I'm done on that side, I turn the microscope so that I'm sitting supratemporal, drying the surface of the eye with the Weck-Cel sponge. You need a totally dry eye for this part. And using an inked 27 gauge cannula, I ink the limbus on the right side and then the left side. So remember, I'm inking supranasal and infratemporal, making sure I'm 180 degrees apart. Inking the tip of the cannula, in my experience, is the best way to do this. And then I'm using the fixed caliper from Epsilon, indenting 2.5 millimeters posterior to the limbus from that mark, and then 2 millimeters adjacent, and then marking those indentations. Doing the same thing on the left side in similar fashion. Again, indenting 2.5 millimeters posterior to that mark, and then indenting 2 millimeters adjacent, and then marking those indentations. This is the back of the trocar, indenting 3.5 millimeters posterior to the limbus, switching to a cotton tip, which gives me better leverage to control the eye, tunneling through the sclera 3 millimeters towards that indentation, and then diving down. This way I can best achieve a self-sealing sclerotomy. That's my contralateral limbal incision to externalize a leading haptic. And this is the incision for my AC maintainer. And this is my incision for the iris hooks. Remember, the pupil is really small, and with the AR40 lens, the PMMA haptics, it's rather delicate, and you don't want to be yanking on the haptics just so they can see through the small pupil. Rather, you place iris hooks, and I'm preferentially and strategically placing these iris hooks where they are because this is the location where I'll be manipulating and trying to thread the haptic through each of the needles. This is dispersive viscoelastic, and this is the 3 millimeter keratoma incision. I'm making the incision supratemporal, which is again perpendicular to those limbal ink marks. This is iris hook. Pull the stopper back. Try to hook the edge of the pupil. Now the problem here is because I pushed all that dispersive viscoelastic, the pupil margin is pushed all the way back. And so probably shouldn't have done that. And so you can see I'm struggling, but finally I get it. I hook the edge and I cinch down the stopper. Try to do the same thing for this other iris hook. And I decided, okay, enough is enough. I'm not going to do that again. I'm using my micro forceps to push the hook tip down. And then I pull the iris hook back. I'm able to hook the pupil edge and push the stopper down. Do the same thing on the other side. Again, twirling the tip down, hooking the tip, and then cinching the stopper down. And this is the last hook, turning it down. Turning the stopper and twirling it, catching it, and cinching it down. I decided to move the AC maintainer incision. And this is the pars plana anterior vitrectomy, making sure I clear the vitreous in the area of action. We're going to place the needles through the sclera. This is a 25 gauge needle. I'm going to bend it fairly close to the tip with the bevel facing to the right, and that's to externalize the leading haptic through the contralateral limbal incision. This is the 30 gauge thin-walled needle, bending it 9 millimeters from the tip, and the bevel is going to face towards the main incision. Remember, all of these needles have a syringe full of BSS to avoid any bubbles. This is the left side needle, bending the needle at the hub with the bevel facing towards the contralateral limbal incision. So here we go. This is the emerald cartridge, filling the barrel and the platform with cohesive viscoelastic, placing the AR40 lens. I target now about a -1/2 to a -3/4. Place the lens on the platform, making sure it's seated down, and as you bend the wings, the optic should bend backward. The leading haptic goes through the barrel and the trailing haptic comes out to the back. Placing it through the injector, making sure the trailing haptic is up outside the barrel as you advance the plunger. So now I'm ready to go. 25 gauge needle through the contralateral limbal incision, again with a syringe full of BSS, placing the lens through the incision, the main incision, having both bevels face each other. My surgical assistant advances the lens. I dock the haptic on the bevel of the needle. She advances the lens even more, and more of that haptic is pushed into the needle. I withdraw the needle and the haptic's out. I take over, making sure the optic comes out planar and the trailing haptic comes out, and I sweep it to the right. Turning off infusion, filling the chamber with dispersive viscoelastic. And this is the part where we place the needle through the sclera. I'm moving the anterior chamber maintainer to give me better access. Obviously, infusion is on. I have the fixed caliper, 2.5 millimeters. I'm just remarking and remeasuring. Holding the trocar cannula with the forceps, stabbing the conjunctiva and sclera at the first mark, flattening out, staying nice and flat, tunneling 2 millimeters towards the other mark, and then diving down towards the optic nerve. Pulling the contralateral haptic out more, sliding the trailing haptic into the eye, sweeping it to the left, docking the haptic on the bevel of the needle. Two pushes and then I'm in. Oh, it slipped out. So I just start again, no big deal. And I notice here that I accidentally knocked off the other iris hook. So again, two pushes and then I'm in. Just trying to double check. Disengaging the needle from the syringe. Pulling the leading haptic into the eye with microforceps, setting it into the angle, and then measuring again 2.5 millimeters with the fixed caliper. Holding the eye with counterfixation. Stab the conjunctiva and sclera at the first mark, and then level off, stay nice and flat, tunnel through the sclera, 2 millimeters, infusion is on. I can feel the resistance of the needle through the sclera, which means I know that I'm through the entire scleral tissue, that entire length. Dive down towards the nerve. Turning the needle to face the haptic, you can see how rotated I am. I'm almost like parallel to the limbus. Docking the haptic on the bevel of the needle, 2 pushes, and then I'm in. So turning that needle so I'm more, parallel to the limbus really is very helpful, so you don't have to put any traction on the haptic. Pulling the left side needle out, but limiting how much haptic comes out, grasping it with microforceps, drawing the haptic, and then cauterizing the tip. Lifting it up and cauterizing a little bit more. You can see how flat the haptic is sitting, flush to the sclera. That's the right position. Pulling the right side needle out, but turning the anterior chamber maintainer away from me. Pulling the needle out away from me, As I pull the needle out, I'm going to grasp the haptic, limiting how much haptic comes out of the eye. This limits how much stress is on the optic-haptic junction. Drying the surface, turning off infusion here, and then cauterizing the tip. You can see how nice and flat the haptics are, again, which is the opposite of the flagpole sign. By having a flat position, that means it's going to best approximate an in-the-bag IOL placement. Turning on infusion, pushing the haptic flush to the sclera, reapproximating the conjunctiva, first on the right side, and then now on the left side. I'm pushing the haptic flush to the sclera, and then reapproximating the conjunctiva. Taking out the iris hooks, you just hold the proximal hook, pull the stopper back, twirl it, and disengage the pupil edge and pull it out. Do the same thing, grasping the stopper, holding the proximal iris hook, twirling it, and taking it out. Super easy. This is a 10-0 nylon suture to close the main incision. Removing the viscoelastic from the anterior chamber. You can see how floppy the iris is. I'm taking the trocar cannula out. This patient has multiple surgical PIs from the original surgeon who did the ACIOL, so I'm not going to make an additional PI. Removing the viscoelastic from the anterior chamber, taking the trocar cannula out, taking the AC maintainer out, and then I'll hydrate my incision. So again, the patient had a vitrectomy before, and I did some more pars plana as well as limbal vitrectomy, but I did not encounter any vitreous throughout the entire case. I'm hydrating my incisions now. This patient had a tiny pupil with an anterior chamber lens. Again, this patient had a really borderline corneal endothelial health, and so I was reluctant to originally do her surgery, but the cornea healed up and everything was doing better. The vision was actually not bad with refraction, but there was quite a bit of cylinder, and the patient had episodes of pressure spikes, also with some CME. So ultimately I decided to take the anterior chamber lens out through a scleral tunnel. You saw that the haptics just snapped off. I then placed iris hooks so I can better visualize when I'm trying to pass the haptics through the needle on either side. So I preferentially retracted the pupil in a rectangular configuration. I docked the haptic, the leading haptic on the bevel of the needle, externalized the leading haptic through a 25 gauge needle passive docking technique. I went after the trailing haptic. You can see how easy I'm able to access the trailing haptic to cannulate the right side needle. Again, docking the haptic, really easy. Just a couple of pushes is all you need, and it grips that haptic so well. Doing the same thing on the other side. And you saw when I turn and rotate the needle almost parallel to the limbus, I'm able to dock the haptic, the leading haptic on the bevel needle so easily. Again, 2 pushes and it grips it so well. Cauterize the tips, and then you saw how flat the haptics were, and that means I have really good positioning of the lens relative to the in-the-bag IOL predicted refraction, and this patient did very well. So I hope this was helpful to you, and I thank you for your attention.